So I'm one of the PGY lives in cardiology, and today I'm going to be just giving an overview of, I would say, in quotations, common cardiac masses and echo findings that would suggest differentiating them. So learning objectives today are to approach the differential diagnosis of cardiac masses, identification of benign versus malignant masses in the heart and specific echo findings, and workup and management of cardiac tumors. So first, I'm going to present a case that I saw earlier in my C1 year. So this is Mr. X. He's a 27-year-old male who presented with a 1-month history of abdominal distension, chest pain, and dyspnea to the emergency department. He had an upper respiratory tract 1 month before his presentation when he was diagnosed with sinusitis and treated with antimicrobial therapy. His outpatient workup, a little strange for an upper respiratory tract infection, but included an abdominal ultrasound because of this abdominal distension, which demonstrated hepatic enlargement in ascites. So his initial physical exam demonstrated a heart rate of 106, a blood pressure of 115/85, and an oxygen saturation of 100% on room air. His initial bedside echocardiogram demonstrated a large circumferential pericardial effusion with early signs of cardiac tamponade. He had palpable ascites clinically. He had a CT abdomen pelvis done because he is a 27-year-old gentleman presenting with this. And there was no evidence at that time of abdominal pelvic malignancy, but it did show moderate ascites, enlargement of the liver, and some periportal edema secondary to venous congestion. So he did have significant hepatic dysfunction at this time. The CT chest also showed large circumferential pericardial effusion, similar to what we saw on echo, and they recommended clinical correlation for this. His initial blood work showed a CRP of 7 and an ESR of 4, which are inflammatory markers, and surprisingly actually lower than what was expected at the time, because if you have an infectious etiology for a pericardial effusion, you'd expect your inflammatory markers to be high. His LDH, which is a marker of sort of tissue breakdown in the body, was 1196. We often associate this with things like malignancy, and his troponin was less than 2. So this is just a representative ECG. I didn't have access to his actual ECG anymore, but what you can see is a 12-lead ECG here. Patient's clearly tachycardic, sinus tachycardia, and what you can see if you look closely is that you have different sizes of the QRS complex, which is suggestive of electrical alternates, a sign of something that's in between the heart and the chest wall and moving. The amplitude of the QRS complex is also quite low here, so suggestive of cardiac tamponade clinically and bedside echo and on CT. So his chest CT, just to show you, so he had a large circumferential pericardial effusion here. He also had bilateral pleural effusion. So if you see this inclusion here, this is on the right side of the body. So he had a bigger right than left, but did have fluid in his lungs. And he also, I unfortunately couldn't scroll down on this one, but had an involuting anterior mediastinal mass. So initial workup and management. So an urgent pericardiocentesis was done, which demonstrated initially 1.2 liters of serosanguinous fluid that was aspirated for a total of 1.6 liters removed. The fluid was sent for sensitivity, culture and sensitivity, cell count and cytology, which all came back negative. His ANA was negative to look for a rheumatic or rheumatologic disease. It was presumed to be secondary to a viral infection at the time with the sinusitis 4 weeks ago, and he was discharged home on high-dose aspirin and colchicine for his pericardial effusion pericarditis. So just for people who don't know what a pericardiocentesis looks like, we usually do them blind here, but I just wanted to show a quick video from NEJM just demonstrating what we actually do. So I'll just show this now. So this is a patient who's quite acutely unwell. We usually mark the spot rather than do it under direct visual guidance, at least in Toronto, and insert a needle. This is subxiphoid, so a subxiphoid approach. And you'll see in a minute, they're actually going to show you aspirating it and looking in the pericardium for where the needle is. So just to get a sense of sort of what we do. Oh, sorry about the back and forth. I was just trying to get the right images. Sorry about that. Give me 1 second. I'll just fast forward a little bit what I wanted to actually show. my trimming of the video didn't work here. So here's on echo. You can see the needle coming into the pericardial space, and we aspirate out of there. So this was his post-procedure echo. And what you can see is a peristernal long axis view here. Small trivial anterior pericardial effusion, looks a little bit bigger on the inflow view. He had a pleural effusion there as well. This is the short axis at the level of the aortic valve. But really just a pericardial effusion here that was residual. I'll just let this play through quickly. And on the subcostal, the reason why I'm showing a bad subcostal is you'll see in a second what we found. So unfortunately, he represented 4 weeks later with a reoccurrence of his symptoms. A repeat echocardiogram was completed, and he was transferred to CCU, because I'll show you what it looked like. And he, unfortunately, over this time had decreased appetite, fevers, and weight loss, so he was quite sick. So this is his repeat echocardiogram 4 weeks later, and what you can see, there's something here now that wasn't there, and his pericardial effusion is now quite complex compared to how it looked before, but he has a big mass sort of sitting over the right atrium now that wasn't there previously. And when you see the subcostal, it's actually quite impressive. It'll come in just a second. Yeah, so if you look at the subcostal there, he has a massive, something new that developed over the course of 4 weeks that we didn't see initially when he presented it. So CT chest was done, which basically showed a large, extensive mass overlying the right heart, as denoted by the red circle sign there, clearly evident on the contrast films. And it's extensive. It unfortunately invaded into the superior vena cava, and there's still a pericardial effusion, as we saw in the echo. So we tapped him. So we did another pericardiocentesis. This is what his post-pericardiocentesis TTE looked like. So still a big mass. The pericardial effusion's a little bit better, but something going on that wasn't there 4 weeks before. So rapidly progressive. So just to discuss cardiac masses, this is out of a review article that shows the differential diagnosis of cardiac masses. So basically what we're looking for is tumor, thrombus, vegetation, or structural. You can use a lot of different imaging modalities to try to sort and parse this out. This is just the breakdown of sort of what the tumor side of things looks like. We're going to talk about the first 3 today. And if you look at this picture here, it just kind of demonstrates where we find different cardiac masses and where you expect to find them. So in the left atrium, you often find thrombus. We talk about left atrial appendage thrombus a lot. Myxomas or lipomas. On the valves, of course, we think about thrombus, we think about endocarditis, fibroelastoma. In the left ventricle, you can get thrombus, especially in the context of apical hypokinesis after an MI, which we'll talk about shortly. In the pericardium, you can get lymphoma, thrombus, lipomas, and one other tumor that we'll talk about sort of at the end of the talk. In the right ventricle, again, you can get, so basically you can get thrombus in any chamber is the bottom line here. Lots of cancers in any chamber. Myxoma is usually in the atria, but we'll go through each one individually. So the first one we'll talk about is cardiac thrombi. So this is a nice diagram that demonstrates sort of different places that we can see clotting of blood sort of in the heart. So on the right side, you can get, most of the time it's associated with mechanical insertion of some sort of device. So often we see them around deep thrombi. They're best diagnosed with TEE, but we will show you a TTE in a second of one of those. The problem with them is they can embolize distally and cause things like pulmonary embolism. The bioprosthetic valves also, you can get clots on. Obviously, we anticoagulate people who have left-sided valves, so aortic valves, mitral valves. Left atrial thrombus is what we think of most commonly in atrial fibrillation. And then the left LV thrombus we often think about when you have some sort of stasis of the impact, so in the context of an MI. So here we'll look at an image from St. Mike's just of a pacemaker thrombus. So if you see here on the still, you can already sort of see what we're going to be getting at here. So this person, this is a right-sided view, and what you can see here already is something that shouldn't be there. So we'll play this through. You can see the lead coming down here. And then this is the thrombus here, and this is a modified right-sided view as well. You'll see it come in on the sweep images in just a second. So you can see it right there. Then this is just a zoomed up view and it's very nice because you can see the lead as well. Here we're just going to look at an apical 4-chamber view. Oh, if I press play properly, we will. And what you'll see in the non-contrast images is just apical hypo or akinesis. Then on the contrast images, you can see that there's a filling deficit at the apex here, suggestive of an LV thrombus. This is actually a very cool case that I saw when I was an R2 here doing ICU. So this is a lady, it was taken on my phone actually on bedside ultrasound. So this is a lady who unfortunately 30-something who broke her ankle and was sent home to wait for surgery. She was obviously immobile during the time. They took her to the OR. And when I was on ICU, we got called emergently because this is what they saw on bedside echo. So I will play this now, show you. I'm sorry it's small, but again, it's a video. So the mouse is pointing at sort of a thrombus there. So this lady actually had a clot in transit. So we actually caught a DVT going up and going into the heart, eventually going to the systemic organs. She was actually okay. We heparinized her. Obviously dangerous to heparinize people after surgery, but what's more dangerous, to let somebody have a PE or to deal with the bleeding from a surgical perspective? But she did very well. So management of cardiac thrombi, so they can be formed in any chamber of the heart. They can cause significant morbidity or mortality if they were left untreated. The treatment depends on the chamber identified. So LV thrombus, still gold standard treatment is warfarin. Some people are now using DOACs, although there hasn't been a large clinical trial to prove its efficacy. If it's a left-sided atrial appendage or right-sided thrombus, DOACs have been shown to demonstrate similar efficacy to warfarin. And treatment duration varies depending on the underlying etiology, whether you can get rid of the underlying substrates, what the indication is, why it happens. So people with malignant thrombi usually end up on lifelong anticoagulation. Somebody who, had an apical hypokinesis, depending on if they get any function in their APEX back, that's a discussion, but generally it's at least 3 months of therapy. And there has been studies done, the Commander Heart Failure trial, which looked at whether or not people who have a focus for stasis, so not appropriately contracting ventricles, if there's any role to prophylactically give them anticoagulation, prevent thrombus, and it didn't show any benefit, unfortunately. So that's why we don't routinely anticoagulate people with reduced ejection fraction. The next set of cardiac inclusions that we'll talk about is endocarditis. So generally, these are right-sided lesions secondary to bacteremia. They can happen on the left side. They can also happen in the context of autoimmune or inflammatory disease, like in lupus. You can get lipid sacs endocarditis. The most common bugs are staph and strep species. And generally, they're treated with long-term antimicrobial therapy or surgical intervention. So surgery is considered when you have valve dysfunction with signs or symptoms of heart failure, left-sided endocarditis with Staph aureus, or highly resistant organisms or fungi, things that are difficult to treat. If you end up with heart block or annular aortic root abscess, persistent bacteremia or fever, complete removal of intracardiac devices, so like pacemakers and ICDs, are often indicated in these patients, although it's a very difficult procedure, and relapsing and remitting infection. So if somebody's been treated and then they get infected again or have embolic events, they'll often go for surgery. These are the criteria clinically. I know that this is echo rounds and we'll get back to the echo in a second, but just to diagnose endocarditis. So what we look at are pathologic, minor, and major criteria. And definite endocarditis is if you have one or more pathologic criteria, 2 or more major criteria, 1 major, 3 minor, or 5 major. So there's a very clinical diagnosis in addition to echo findings. So to show you an example of aortic valve endocarditis here, you can see that there's something going on with the aortic valve where it doesn't look totally normal. And when you look at the short axis, I'm sorry, it's so fast with the sweep, you can actually see something coming in. That's abnormal, and we'll talk about the findings suggestive of endocarditis in just a second. And then here's the 4-chamber view or intermittent 5-chamber, and then we'll show a close-up of the aortic valve in the 5-chamber view with a sweep here. And you can see that there is something sitting on that aortic valve. My mouse works right there. So there are also like very definitive physical exam findings for endocarditis. So basically what can happen is pieces of this can break off and shoot out to other parts of the body. So if embolic, you can see things like splinter hemorrhages, which are small bruises at the tips of the nails, Janeway lesions, which are on the palms and are usually non-painful, Osler nodes, which usually happen at the tips of the fingers. All of these are embolic events. So when things break off from the vegetation and go elsewhere with septic emboli. Obviously, you can hear a murmur associated with it, and if the aortic valve is involved, we always worry about complete heart block because the aortic valve sits right behind the, right in front of the AV node. If you have a big enough abscess, it can compress the AV node and cause arrhythmias. So this is just out of the ASC guidelines looking at echocardiographic features of infectious endocarditis and abscess. So the first thing we look at are vegetation, so echogenicity and the echo texture. So healed vegetations can look more chronic. Sorry, I didn't mean to go forward. And are more echogenic and often calcified. Size, unfortunately, is highly variable depending on the type of disease it is, what the infectious bug is. The aspect shape, it's usually amorphous, lobulated. It's less commonly linear around, although we do see linear inclusions. Location, it's usually on the atrial side of the AV valve, so on the low pressure side. But on the so all of the low pressure side, so the atrial side, where the atrial ventricular valves, and on the ventricular side of the aortic valve. The motion is high frequency, it can oscillate. It's independent of valve motion, which I think is probably the key feature of it. And if it's large, it can prolapse into the ventricles during diastole. You can get valve regurgitation, you can get mycotic aneurysms, destruction of the valve, abscesses, and prosthetic dehiscence. And in terms of abscesses, so going beyond just the valve inclusion itself, you can see echolucent or echogenic heterogeneous space or tissue thickening, which may not fill with Doppler color because it's not vascular. I'm obviously not an expert in TEE, but just to show you, there are some benefits of surface echoes versus TEEs in these cases. So for LA thrombus, we always think usually of a TE because it's better visualized. For aortic atheroma, they say TEE. Prosthetic valves often will put a probe down and take a look. And then if you have apical akinesis or hypokinesis with contrast, it's very good for LV thrombus. So the next thing we'll talk about is benign cardiac masses, and I put benign in brackets because we'll have a look at what these look like, and you can tell me if you think that some of these findings and effects are benign or not, because we're talking non-cancerous here when we say benign. So the first one is a cardiac myxoma. So it's the most commonly resected cardiac mass. It's most often identified in the left atrium, right atrium, but can be in the ventricles as well. Its distribution involves all ages, more common in females. Its presentation is often asymptomatic until you have an embolic event. If it's on the left side, you can end up with a stroke. If it's on the right side, you can end up with a clot in the lungs or a pulmonary embolism. But they're most commonly neurologic findings. So that's why I say, like, is it really benign if somebody has a stroke? But I guess benign in the sense of non-cancerous. Its treatment is resection. Recurrence risk is common, usually the same at the site. And its risk of recurrence is highest with a ventricular tumor, a smaller tumor if it happens in a male patient, or a resection with an endocardial button. Don't ask me what that is. Ask the surgeons. I have no idea. Here's an example of a cardiac myxoma that was taken at St. Mike's. So what you can see here is there's something that shouldn't be there, sort of traversing the intraatrial septum, and it's actually very nice to see in the short axis here that it's going from the atrium to the ventricle. And I just showed the contrast images here just to show that they're usually avascular, so they won't contrast enhance. I'll just put this out. And then this is the 2-chamber, the 3-chamber, and then the subcostal. So you can sort of see it in all views. It's pretty big. I don't know why it keeps doing that. Sorry. My God. It's big, eh? I call this kind of stuff like the C1 or the C2 sign, you know, like if we can see it, it's usually pretty big. I guess I should say C2 now that I'm not seeing it. So echo features of cardiac myxoma, it's usually a heterogeneous mobile mass, as we saw. There are two sort of classifications of myxoma. The first is polypoid. It's a large, smooth surface with a rough core, and it's more often associated with obstruction. So you can get things like LVOT obstruction, you can get atrial to ventricular obstruction. And then you can have a papillary form, which are smaller, they're stretched, they have multiple villi, and these are more associated with embolic phenomena. The next tumor, or the next one we'll talk about, is a papillary fibroelastoma. So it occurs in all age groups. It can affect all valves of the heart, more often aortic, then mitral, then tricuspid pulmonic, so higher pressure valves. And it can be present on more than one leaflet of each valve. It's rare to cause frank valvular disease, but 27% of patients often present with embolic phenomena, including stroke. Anticoagulation has been looked at in these patients to see if it reduces the risk of sort of stroke, and it unfortunately hasn't, which makes sense if you think about it. It's not actually a thrombus. So anticoagulation won't break down the pieces of the tumor. And they often will resect them for left-sided lesions to prevent further embolic event. So here's an example of an aortic valve papillary elastofibroma, and you can already see it there. It looks a little heart-shaped on the aortic valve. So we'll play this through. You can see there's that little thing moving there. That's a zoom up of the aortic valve. Short axis, you can see it there as well, and you can also see it in the 5-chamber here. And I have to stop just pressing the next button because apparently... So echo features of papillary fibroelastomas. So they're small in size, as we saw. They have independent motion. They're often attached to the endocardial surface. They have stippled or shimmering borders, which apparently is better seen on TEE than on transthoracic. And they're generally attached to a central pedicle. So few identifying features here. The next set of tumors that we'll talk about are malignant cardiac tumors. And I apologize, I'm moving very quickly through this. So we'll take our time with this one. So the first one we'll talk about is cardiac sarcoma. So cardiac sarcoma is a primary cardiac cancer. It portends a poorer prognosis than non-cardiac sarcoma. So sarcoma is often a cancer of younger people. It can happen in the bones. It can happen in the muscles. And if you have a primary cardiac sarcoma, unfortunately, the mean survival without treatment is about 6 months. And if you get treated, it's about 93 months. So you do get extra time, but it portends a very, very poor prognosis. They're rapidly progressive without adjuvant therapies. So adjuvant therapies being chemotherapy, radiation, surgical resection. If the margins aren't clear post-operatively, often we see that these occur at a very high rate. Angiosarcomas are right-sided lesions, so there's various subtypes of sarcoma. They're often seen in the right atrium. There's intimal sarcomas, which are left-sided, and unfortunate differentiated sarcomas, which means that they get a piece of tissue and they can't tell you what kind of tissue the original cancer was from. And these are portend the worst outcome, unfortunately. They often metastasize, so most often to the lung, greater than the liver bone and greater than the brain. And the treatment is surgical intervention is better than none, but outcome remains poor. And we'll talk about chemo and radiation here. We'll talk about this in the next slide with a paper, but any therapy adds early survival in the first year. But after the first year, you'll see that the Kaplan-Meier survival curves sort of come together. So this is actually out of JAMA because oftentimes when we do echoes, we don't know what the primary is. So we just see a cardiac mass with echocardiographic features and we can't necessarily tell. So I wanted to show you a confirmed case of sarcoma here. So this is out of the JAMA website. And what you'll see is that sort of big mass here, not moving, attached to the intraatrial septum. Looks very different than sort of the myxoma that we had before, and also the papillary fibroma, which was small. And you think I would figure out these buttons already? Echo features, often lobulated masses. They're distinctly heterogeneous. They can have areas of necrosis or hemorrhage. So they may or may not uptake contrast when you use them. There's no stalk, which makes it different than a papillary fibroelastoma or myxoma. And there's often direct involvement with the pericardium, and they often present with an effusion. Angiosarcomas can completely replace the right atrial wall and fill the entire cardiac chamber, which means that they can cause obstruction and decrease blood flow. And they often develop near the right AV groove, and they can affect function of the tricuspid valve. So really, not only are they malignant from a cancer perspective, but they're malignant from a heart perspective as well. These are Kaplan-Meier curves just looking at the survival rates of patients with a cardiac sarcoma. So what you can see is in the graphs here. So you can see survival probability on the left side. So 100% means 100% survival rate. 0 means 0%. And on the bottom, you'll see years. And what you can see in this one is without treatment, the red lines sort of show that they're low. So the Kaplan-Meier curves come together here. But the one I really wanted to show you is this one here in the bottom left. So what you can see, the red line in this case is actually with treatment. So they had surgical intervention, chemo, rads. And the blue line is with treatment. The red line is without treatment. I apologize. What you can see at the beginning is that there's separation between the Kaplan-Meier curves here, which means there's increased survival of these patients. But by the time you sort of get out to the 2 and 3 year mark, and same in this graph here, you can see that the curves sort of overlap, which means that there is no more increased survival for these patients. The next type of cardiac tumor that we'll talk about is a cardiac lymphoma. They're rare phenomena of primary lymphoma, not metastatic lymphoma, accounting for 1% of cardiac malignancies and 0.5% of extranodal disease. If they're untreated, they portend a poorer prognosis, and survival can sometimes be less than a month. This is for primary cardiac lymphoma. With secondary or metastatic cardiac lymphoma, they often respond very well to treatment. They're mostly right-sided tumors, with the atrium being affected in the same sort of distribution as the ventricle. And they're generally large B-cell lymphomas when you take a piece of it and take a look under the microscope. Treatment's primarily chemotherapy, and it can increase survival to about 5 years. So this is just a picture of an RA mass, suggestive of a primary cardiac lymphoma, again, for JEMA. Echo features of lymphoma, primary, they appear as homogeneous, infiltrating masses leading to wall thickening. They can demonstrate restrictive hemodynamics on echocardiogram. They can have an alternative appearance where they can be nodular masses intruding into the cardiac chambers. They preferentially affect the right-sided structures, and the AV groove can be affected here as well. The pericardium can be involved, so you can get effusion most often, or effacement of the pericardium on bedside echo. And then again, depending on the size of the tumor, I apologize for that spelling mistake, you can get inflow obstruction as well. Cardiac mesothelioma, so it primarily affects the pericardium rather than the heart itself. It's an extremely rare malignancy with an incidence of less than 0.002%. It can invade the myocardium, but again, it's most often a pericardial tumor. And its presentation is heart failure if it's invaded, essentially. Tamponade, you get constrictive pericarditis with chronic tumor in the pericardium and present with pleuritic chest pain. It's linked to asbestos, which is what you think about with lung cancer, is less and is more ambiguous or like less associated than pulmonary cardiac mesothelioma. And its mean survival, unfortunately, is 2 to 6 months. So this is an example of a cardiac mesothelioma, and what you can see from Mayo Clinic, and what you can see here is that there is a big tumor here that's sort of sitting outside the heart. When you look inside the heart, you can't really see it as well here. So I think that's what we're trying to show. Echo features, you can get bulky nodules within the pericardial cavity. It can encircle the heart. It can mimic pericarditis or tamponade or restriction. And discrete mass may not be seen, so you might not actually see a cardiac mass here. This is a nice picture of a CT scan from a paper in 2021, which just shows that you see the heart here on CT, just to point it out. And then you have this big mass here that's sitting outside the heart, sort of irregular borders consistent with a cardiac mesothelioma. The next sort of category that we'll talk about is metastatic disease to the heart. So it occurs in 1.5 to 20% of all cancer patients, so big range. Its most common primary tumors are melanoma, lymphoma, leukemia, carcinoma of the breast, lung, and esophagus. So that's where you'll see mets to the heart from most commonly. Its presentation is non-specific, but it's dependent on tumor burden. Again, these people can present with chest pain, heart failure, obstruction, just depending on where the tumor goes. And its most common symptoms, as I said, are dyspnea, palpitations, can develop flutter, fib, chest pain, and peripheral edema. Structure affected more so the pericardium than the epicardium or myocardium. So you can get different spreads to the heart. So I know that this is very clinical and we're at echograms, but just to give a brief overview. So you get spread through the blood. You can get spread through the lymphatic system. And then you can also get transvenous extension. So you can get compression of different structures leading into the heart. You can get, and then you can also get direct invasion of cardiac structures. So what you'll see here is just gross pathologic structures. In picture C, you have metastatic renal collecting duct carcinoma filling the pericardial space and encasing the heart, resulting in a constricted physiology for this patient. In the middle diagram, you'll see gross photograph of T-cell lymphoma involving the myocardium, because so you can see that the myocardium is quite thick here, kind of equivalent to a short axis view that you see on echo. And you can see in picture E a large endocardial metastasis from a malignant peripheral nerve sheath, so very uncommon cancer, involving the endocardium in a patient that had a very rare condition called neurofibromatosis type 1. So just to show you that metastatic disease to the heart can go anywhere, and it can cause big problems, bottom line. So in summary for the malignant cardiac tumors, because I know we did like a quick whirlwind, lots of clinical stuff here. Overall, they have very poor outcomes, unfortunately. They have an extremely high mortality rate, and the earlier we can identify these lesions and get people treated, the more likely they are to at least have a better quality of life for the time that they have left. Early results, again, are improved with surgery and neoadjuvant chemo and radiation, which is why it's very important on echo that we understand what these look like to sort of get these people to the right doctors in order to be treated in an efficacious and early manner. And total resection without evidence of microscopic disease is the goal of surgery, so they try to resect the whole thing. Back to the case. This young gentleman had an IR-guided biopsy, which demonstrated, unfortunately, undifferentiated spindle cells consistent with a synovial sarcoma, which was rapidly progressive. He had chemotherapy initiated. He actually underwent surgical debulking and is, from what I can tell, is doing quite well post-operatively. And so the big thing that I learned from this case, and I think to sort of put forward, probably not for the echocardiographers in the room, but for the clinicians, is if you aspirate an unexpected bloody effusion, after you aspirate, you should always do a CT scan just to look for underlying malignancy. So I rushed through it. I'm sorry, I always talk fast when I do these. If anybody has any questions, I'm happy to field them now.
Thank you, Jamie. That was a whirlwind of cardiac masses.
Yeah, a little fast. It was more like a tornado.
The Twisters, latest movie in.
Yeah, that's right. I was trying to emulate popular culture.
No, but yeah, that was very good. So I'm open the questions to the audience. Please go ahead. Any comments from the group? Maybe Priya can open up the camera for the conference room. There we go. So any questions from anyone? I guess the clinical pros is always like, we see a mass and then you always need the clinical context to try to figure out what it is and to make the best guess. The typical answer that we always have is a mass could be a clot, a tumor, or endocarditis. Typically, those are three natural response. And then we need a lot more data from the patient's records to try to figure what it truly maybe. And it's not infrequent over the years that we felt there's a clot could be a tumor, but we put the patient on anticoagulants, and then the mass actually went away. So we proved that was a clot instead. So that has happened to us in a few patients over the years. The controversy remains about, dissolving clots in the heart, especially LV thrombus, whether we could use NOAC. So anyone in the group have the latest updates on that particular topic?
My understanding is that there hasn't been a global clinical trial done yet, but people are using it from a practice perspective, because the thing with warfarin is that there's a lot of maintenance that needs to happen with it, right? You need to follow INRs, you need to make sure people are therapeutic, patients need to take it, they need to be compliant. Obviously, patients still need to take their NOACs or DOACs, but there's less surveillance needed with them. So I think in practice, people are starting to use DOACs, but I don't know of a clinical trial that's been published yet.
It's
in progress, right?
There's 5 or 6 small RCTs that are about 45 to 50 patients each. Enough of it's been enough such that the latest scientific session, or the AHA scientific statement on this, suggests kind of equivalent use between DOAC and warfarin for LV thrombus. I feel like if you talk to 10 different people, they kind of give 10 different answers. I've had bad strokes on DOACs. People have had bad bleeds on warfarin. I think it's something that's ripe for a multi-center, we should just answer this now, trial.
I think the initial bulk of the evidence suggested that perhaps warfarin was still better, but more recently, I think with more data, I think it's swayed now towards DOACs, and you can't beat the convenience of DOACs.
Yeah, exactly.
Warfarin, in all honesty. But you're going to have failure of both, right? I think as clinicians, we've kind of seen events happen on both agents. Warfarin, obviously, the INRs tend to vary so much, right? That you can have bleeding and embolism related to that. But I think a true RCT comparison, at least for LV thrombus, I think would probably be the way to start, right? Because that's probably the most common intracardiac thrombus that we see, as opposed to valvular or other types of thrombi.
Yeah,
there's a question sitting on the chat.
Sorry? Oh, let's see what is in the chat. Let's see. So I'll read it out from Josh. I know that contrast can possibly show if there's vascularization. How helpful is using contrast in assessing masses in the heart?
Yeah, sorry, I can take that one. There have been a number of, case reports, case series on looking at contrast for vascularization masses. The best one was well over a decade ago by the group at the University of Chicago with Roberto Lang that suggested you could differentiate avascular versus polyvascular versus more vascular masses. I would say that we tried it here. It's fairly heterogeneous. I think part of it is, I think for larger masses that are relatively immobile, it's easier to look at contrast for perfusion or vascularization. For the more mobile masses, particularly attached to valves, for example, I think it's less useful. We do try it. I think there are times where we're very convinced that there's good vascularization. Having said that, I think in terms of the parameters that we use to assess cardiac masses and its etiology, it's probably not in the top 2 or 3 factors. We look at location, appearance, the clinical context as being more important for differentiation as opposed to the vascularity. But I think I think contrast is more useful for delineating masses, period, that we have difficulty detecting without the use of contrast for the classification of the chambers. And it's more helpful for ventricular masses than atrial masses, just with regards to, at least for transthoracic, it's the atria tend to be a bit deeper in the field and could be shadowed. And we've tried to use it on T as well. Sometimes we try to use it, but unfortunately T does not have good contrast specific presets to allow us to do that. But we do try it.
Yeah, sometimes I find it very hard with the contrast with the like sometimes we see it well and sometimes we don't on the echo side.
Yeah, I think the better the image quality, the more likely we'll get decent perfusion, and the less mobile, the more likely. When it's very mobile, it's like solid.
Yeah. Well, one of the field of research was a while back was actually looking at this how to distinguish a clot versus a mass by looking at the vascularity. So I guess that never actually completed this course because it's actually very hard.
Yeah, like I said, the best study was Roberta Lang's study from over a decade ago. So that was published in Jack or Jack Imaging, one of them.
Yeah. Okay, well, thank you, Jamie, for this twister of presentation of masses in the heart.